Well, good afternoon to you. Welcome to the Warrington Health and Wellbeing Board for today, and to welcome everybody who's joined the meeting and those people who are watching this on Facebook. First of all, can I thank you all for your dedication, your focus through the last 4 months in supporting the response to the COVID epidemic. It's been a really big town-wide effort to support people during this time, and just to thank you all. We may have not found the vaccine for COVID, but we've found some form of drug that's made us work much more cooperatively together than ever before, and I think it'd be really helpful if we can try to continue that as we learn to live with COVID going forward. So are there any apologies, Jenny, I need to be aware of, please?
Yes, we have apologies from Councillor Pat Wright, Dr Davies, Dr Watson and Colin Scales and Paula Worthington.
Okay, thank you. Any others, please? Okay. Just to remind you, if you want to raise an issue or a question, just use the hand function. He's in the control bar in the middle of your screens, please. Just raise the hand and I'll keep an eye on people who want to raise any issues. Thank you. So code of conduct, if you've got any issues in terms of declarations, just let Jenny know, please. Just send her a message. You can do that again using your control bar. Minutes of the last meeting on the 23rd of January. Can I take those as a correct record, please? Just ask one person to say yes, and I'll go with that.
Yes.
Who was that?
Simon Kenton.
Thank you, Simon. Are there any matters arising, Simon, that you want to bring to our attention from the minutes of the 23rd of January, please?
None from me, Chair.
Does anybody else want to raise any item from the minutes of the 23rd of January, please? In which case, thank you. I move you to item number 4, updates from reference groups. I'll take the ICTB first then. Kath Jones, please. I think you're speaking to this.
Yeah, can everybody hear me? Yes, I'm on mic, aren't I? Okay. Yes, so I'm just providing an update on the work over the last few months since January of the Integrated Commissioning and Transformation Board. As everyone will be aware, the membership of that board is CCG colleagues, local authority, cabinet members, public health, Health Watch Warrington and Warrington Together. And basically what we do in that group is look at our commissioning intentions and our commissioning plans and work on those together. Over the last 4 months, the focus has very much been of that commission, the ICTB as we call it, on keeping our most vulnerable people safe and at home as much as possible, and also keeping the flow through our acute and hospital to ensure that we discharge people to the right destination as soon as possible. Now, what actually happened when the pandemic started in February was that a lot of our business as usual meetings, including ICTB, were stepped down, whilst all the partner organisations focused really on working out what the priorities were in terms of managing the pandemic and planning for what was to come, because at that point as well we thought there would be a much more significant surge than we had. So ICTB was stood down during that period. However, as the progression of the pandemic levelled off somewhat, and as monies became available, grant monies from the government, we recognised that it would be really helpful to step back up ICTB, so that we could work together on a joint approach for the prioritisation and allocation of all the grant money that was coming down, both through the NHS and the local authority. And to date, there's been 4 million of aligned investments that we have worked through together to ensure that that is distributed in a way which meets the needs of our population, both across health and social care. So as from April, we actually stepped up the group again. We met more frequently, we met fortnightly, and we had pre-planning finance meetings because it was so important that we have a strong and robust audit trail and governance arrangements in place for all the investment decisions that we were making to meet the needs of our population. We also had a process whereby for investments that were over 250,000, they were subject to a much fuller business case, and anything that was relating to additional bed capacity also went through the regional out of hospital cell group for validation. It was because in fact that group worked incredibly well. And because the finance meetings were also really bringing together our planning function, we also decided to extend that to the Better Care Fund steering group, which deals with our wider transformation plans and some of our bigger investments over the last couple of years where we have joint budgets together, joint funding together. So just to give you a bit of a flavour of the investments that were endorsed and approved through the CCG management meeting following ICTB, we have basically in the 4-month period, we have stood up some additional transitional beds which supported the flow out of hospital to ensure that the hospital was supported and ready to receive our most poorly patients. We have funded temporary additional intermediate care beds. We did have an infection outbreak at our bed-based intermediate care unit called Padgate House. And during that period, to ensure that there was no further infection spread, Padgate House was closed for a significant period of time. So we did step up some additional intermediate care beds. We also commissioned some augmented nursing care beds so that we were able to place people coming out of hospital who were COVID positive in units where there was clear isolation processes and procedures in place to ensure again that that was done in a safe and timely way. We also agreed a range of contingency payments to our care homes, to domiciliary care services, and to the range of our supported accommodation projects. We have funded a range of additional staffing, which has generally been associated with COVID management, where we've had to move additional resources into key areas where we've needed to focus. And we have also funded some additional equipment requirements to ensure that we are able to keep people at home because that's the safest place for them. And for a period of time, which has ended now, we did fund a private ambulance service to support the care call response. The group also during that period has had oversight of the development of the Warrington Care Home Support Plan, because as everyone will be aware, that's been an area where we have worked very much as a system to try and ensure that we are providing timely financial, practical, clinical infection control support to the sector who have suffered. So we provided oversight for the care home support plan, which was submitted to government at the end of May, and also around the subsequent allocation of 2.5 million infection control monies, which is to support our providers so that they can secure the staff they need, make sure the environment is safe, and have the support wrapped around both residents and staff. So that's been the focus of work for the first few months. Now, as the situation appears to be stabilising, ICTB are now concentrating on what we're calling reset and phase 2 of COVID planning. And the focus going forward is going to be very much on the priority investment areas through the Better Care Fund, which we developed last year. So there were 3 of those specifically. There was one which was about developing an integrated rapid community response service, which is now fully operational. And the role of that service is to try and ensure when somebody in the community has a crisis that wherever possible, we can respond within 2 hours and keep those people safe at home, rather than them having to be transported to A&E and potentially get admitted. Also on the redesign of our intermediate tier services, both community and bed-based. So that's our integrated reablement services at home, which provides therapy and support to get people as independent as possible when they've had some exacerbation of ill health. And we also are focusing on our enhanced reablement service, recognising that really our priority needs to be on developing community services and making sure that we keep as many people at home with services wrapped around them, because that's where they are likely to remain as well as possible. In this phase, there's actually been many positives. As Stephen was saying, we've come together, worked well across the system, and it's been increasingly recognised as a result of this joint working and some of the acceleration around integration that we've been doing, that there's a really close match with the frailty programme of work, which is led by the CCG. For example, they're working on the projects around rapid community response developments and also around our integrated community teams. So as a result of that, there's now been some wider discussions and thinking amongst partners about how we can develop an integrated work stream with a wider focus. So that's going to be the focus of work going forward over the next 3 or 4 months. So really it was just to give a little whistle-stop tour of the work that the ICTB have been doing to date. I am joint chair with Carl Marsh from the CCG. I don't know whether you want to add anything in there, Carl?
Just to say, Kath and Chair, that one of the things that I've been really struck by during this period is how we've disciplined ourselves as a system to take a response idea to a challenge, turn that into a plan, get that to the Better Care Fund steering group to turn that into a business case, get that endorsed through the ICTB and approved at the CCG integrated management team or the out of hospital cell, and do all that in about 3 weeks and still meet our governance requirements. And I think that is something that we definitely want to retain and take forward the recovery phase and beyond.
Okay, so Carl and Kath, thank you very much for that report. Let's invite any comments or questions, please. If you wish to do so, please raise your hand.
I haven't got a hand to raise, but if I could make a comment, if that's okay. I think I described the ICTB as cooking on gas over the last however many weeks it is now. There really has been a huge sense of common purpose and will to get things done, as Carl has just said, and it's been very impressive. So I look forward to it continuing in the same vein with the same degree of common purpose and cooperation as we move ahead. And I welcome the further consideration that there is at the moment on making sure that we look at further opportunities to sort of develop the work stream and make sure that it carries on in that integrated fashion.
Okay, thanks, Rebecca. Any other comments, please? So just the recommendation is to note the update and the joint aligned investment and plans. So thanks very much for that, Kath. So moving on then to you, Simon, the report of the Provider Alliance and Warrington Together. Simon.
Thank you, Stephen. You'll see there that we've made tangible progress in terms of delivery, integrated delivery. I just wanted the board to be aware of 2 things, really. One is around the potential primary legislation in relation to putting ICSs on a statutory footing. So our geography in relation to Cheshire and Merseyside ICS. And secondly, just to inform the board in relation to the moratorium put on any organisational change for Bridgewater. So Bridgewater will not be acquired by the hospital. It will remain as a going concern for 2 years. So, Chair, if I can just bypass my paper, which hopefully you'll accept, The first is around primary legislation in relation to ICSs, integrated care systems, and secondly in relation to the provider architect.
Okay, Simon, thank you. Any comments or questions, please? So for next time then, Simon, do you think we could just have a short paper on what the statutory powers being given to the Cheshire and Merseyside Health and Social Care Partnership, the ICS, may mean for us? And also, I think they've now agreed a new vision statement in terms of reference to that group. And how does it interface with health and care systems in Warrington? Just a short paper just to remind us what the direction of travel is, please. Yeah.
Certainly, Chair. If I may, I think that the board may want to be a bit more bold in relation to its shaping of that architecture. Perhaps we should say that Warrington Together is the way forward, and that primary legislation should follow that. Okay, well, let's have a paper, Simon, a report for next time. We'll talk about that. Okay. Nothing's going to happen between now and September, first week in September, is there? No, you're right, Chair. Thank you. Any further comments then, please? Okay, thanks for that, Simon. We'll just note that report. So move on now to a presentation, Eileen, on health inequalities and the impact of COVID. So over to you, Eileen, please.
Okay, thanks, Chair. I think this is going to go up, isn't it, on the screen for everybody?
Yes.
Can you all see it? Or is it on its way?
I can see it.
I can see it.
I can see it.
All right, okay.
Oh, well, I can't see it. Okay, I'll bring it up in a different way for me. Okay. Okay, I'm going to look at it on something else, but let me know how it's going. This is a presentation which was pulled together by Liverpool John Moores University. It was commissioned by CHAMPS, by Cheshire and Merseyside Directors of Public Health, to look at what the impacts were of COVID. And the idea is to look at the impacts on the disease in the first wave, to think about what the results of social distancing and lockdown have been, and to also look at indirect health and wellbeing impacts that may have arisen as a result of COVID. So I'm going to move on to slide 4 now. Is that okay? It was carried out at pace. There was a rapid search, and the evidence was scoped and collated from the 18th to the 18th of May to 8th of June. Okay, slide 5. What it does is it looks at what's been the impact on family and friends, and some of it is what you would expect and some of it is slightly different. And I suppose what it does is it tells us what really happened in terms of university-backed research. So a key thing in terms of impact on family and friends, and I know that we saw this in Warrington, was that social isolation and loneliness increased. And with that, we saw a 30% increase in the risk of heart disease and stroke. There was greater toxic stress. There's been a global increase in domestic violence since we've had COVID-19. And the UK has been part of that trend. And so what we've seen across the piece is, that increase in violence, particularly for women. There's also been some hidden safeguarding issues that the LGA has raised about the impact on children. So those are kind of the negative things that came out of that. There were also positive things, and I think we saw a lot of this in Warrington, where we saw an increase in local volunteers. We saw lots of new groups pulling together, and we saw a more united and a kinder approach to things. In terms of the impact on money and resources, which you've got on slide 6, we saw obviously a big increase in unemployment as part of COVID-19, and it's been young people that have been affected most, people who've been on 0 hours contracts, people who haven't had permanent contracts, who haven't been entitled to be furloughed or claim in the same way. And household incomes have fallen, particularly for the lowest earners. We are predicting an economic downturn. And again, as a result of that, we're going to see a big impact on health and well-being. We know that the biggest cause of health inequalities is deprivation. So we are expecting to see poorer mental health and poorer physical health going forward. And we need, as a health and wellbeing board, to think about what can we do to work around that and to acknowledge that as a board, and think about, do our programmes actually address that? If we're moving on from that onto the impact on education and skills, you know, as you all know, we've had children off school for the past 3 months. Not all children, some children have been in school, but a lot of children have been off school. And it's children in the poorest situations that suffer most from being off school for any period. And it's the children from more deprived backgrounds that have spent less time at home learning. That's what the study showed. So again, that has a big impact on health. People with a lower education tend to have poorer life expectancy, don't do so well in terms of health. Okay, next one. So slide 8. The lockdown exacerbated food insecurity, particularly amongst children. The food banks, there was a massive increase in demand for food banks, and the number of adults who are food insecure is estimated to have quadrupled according to this study. So that again is going to have a huge impact on health. Then if we go on to slide 9, there's been, for people who drink, there's been a big increase in drinking. And we've seen more people drinking more often on a typical drinking day. For those people who don't drink much, they've actually cut down. Some good news is that we've increased the motivation to quit smoking, so that's been really good, and we've seen a big increase in stop smoking. But we have also seen an increase in obesity. Obesity and diabetes are 2 of the key risk factors for COVID. So if you are obese, if you have diabetes, if you're on that edge, you're more likely to be affected really badly if you do go on to develop COVID. Long-term conditions have worsened for many people. And what we're expecting is what we call in public health a long tail, which means that the disease is there, numbers go down, but the repercussions of that disease will be with us for a long time. And also we will see clustered outbreaks of the disease. That's what we're expecting to see. And those will be higher in more densely populated areas where they tend to be more deprived. So it's being aware of that. We also need to consider the fact that we've had delayed cancer diagnoses for a lot of people because, for obvious reasons, you know, we've not been able to screen in the same way. And also people have been reluctant to go to hospital because they're worried about catching COVID. So, you know, we're expecting to see more cancers and later stage cancers coming through. And also mental health. The one thing that people talk about all the way through COVID has been anxiety, depression, concern, people really worried about it all. And that's had a big impact on mental health, basically. So that's a key thing that's come through. So that's the report. That's what came through from John Moores University. So there you have an objective view of what happened. It probably mirrors some of it with what you thought yourselves, but it's interesting to see it actually captured by a university, and it's there for us to consider. Okay.
So Eileen, thank you very much for the presentation, and thank people at Champs and Liverpool John Moores University for their support. So take any comments or questions, please. Let's just ask Maureen McLaughlin. Any comments, Maureen, from your point of view?
Hello, yes, thank you. Yeah, as Eileen said, a lot of this we already had a feeling that this was the case, certainly on the different areas covered. I suppose for me, it's where we go from here is having that understanding, and with an awareness of a potential second wave, what actions would we like to put in place now to prepare ourselves for the future, and also again with those long-term impacts, what is it that we need to change, really? So that's my question. Are there, drawing out from this, are there things we can do to protect people better? Okay,
I'll just hold on to that for a second, see if anybody else got any comments. I'll ask you to answer all these. So Rebecca Knowles, any comments from yourself, Rebecca?
I think the thing that really comes out of here very strongly for me is the fact that we talk about this stuff in the Health and Wellbeing Board, and a lot of it is stuff that we were already aware of, and we've talked about being a marmot community, and a lot of this is about wider determinants of health. But the levers to effect change and to improve on some of these factors reside in other bits of the council. So I think it's about joining up the work of the council. A lot of this is about the economic impacts of COVID, because for people who are suffering the worst economic impact, either in their community or individually in their sort of family circumstances, having more money will make a lot of difference in terms of quite a few of the other aspects. So the stuff around skills, the stuff around people having access to employment opportunities, stuff around housing, that very wider work, it all feeds in. The other observation is that we've obviously been on the right lines with the issues that we've prioritised during this first wave, in terms of the things that the council's worked on and tried to make sure there was a strong response and a strong level of support. So I think it's very depressing sort of thinking about the long tail of COVID, but it's also quite heartening to think that we've been on the case early and with impact on some of the most pressing aspects of it. Looking at the one on food, and that always is something that really worries me. It's not just food poverty, shortage of food, it's shortage of access to nutritious food, and I think the longer this goes on, the more it's going to be about having children and adults and older people having access to decent food. So that's something that we're going to need to work on for a long time. So it's complex, and I think we're at the beginning of this, and a lot more work to be done, but a lot of collective will to address it.
Okay, thanks, Rebecca. Just take one other contribution before I ask Eileen to respond. Ian Marks, any comments, please, Ian?
Can you hear me now?
Yeah, I've got you now, Ian. Yeah.
No, I mean, my comments are very much the same as Maureen's. I mean, this is good, you know, good stuff, good exercise. And it certainly sort of chimes in with what I think most of us have been thinking. It's good to see actually a report. But the question is, what do we actually do now? And what are the lessons? A very easy thing to say, that was a good report, some interesting stuff in that, and we put it aside. But it's important we come back to this. Maybe the time isn't quite right yet. We have to sort of wait until things settle a little bit more. But we do need to come back to this and say, what can we actually do that we haven't been doing already? And I certainly acknowledge some very good work has been done by all sorts of people, many of whom are actually in this meeting right now. So I just look forward to finding out what we're going to do, make sure we don't leave this on the shelf. Thank you.
So Eileen, would you like to respond to the three comments, please?
Yeah, thank you. I think you're all absolutely right. We need to think about what we're going to do around this, because it's all very well having a report, but what you need to do is action it. And what I would recommend is that we go back through our Health and Wellbeing Board strategy and think about how pertinent is it to some of the stuff that's come out of this. And I know we've been working on it, but I think at the moment what we've got is a very long list of priorities. And I think that one of the things that comes out of this report is that there's certain things that are more pressing than others. So I think mental health is absolutely crucial, social and emotional health. And that's particularly important for adults and children. Children have been very impacted by this as well. So I think that's something that we really need to focus on. I think also we need to focus on cardiovascular disease and diet and exercise, because if you look at people who've really suffered, a lot of it has been around CVD. It's been the people who've come off worse from COVID are people with diabetes, people with any form of heart disease, and they're the ones that haven't got the diet, haven't got the exercise, and really need some extra help. So I think it's like focusing down and thinking about what can we do about that, because there's lots of things we can do about that. That's quite an easy area to work on, because the CCG can certainly do a lot on that. We can do a lot on that as a council. And also we can get other partners to work on that as well across Cheshire and Merseyside. So we need to think about that. And also I'm really worried about cancer. I feel as though cancer rates are poor anyway. We've lost all this screening and early detection and so on. And I think we're going to really see a big upsurge in cancers, and we need to really think about cancer and what we're going to do around that. So there's that. And also I think the Marmot work that we agreed that we would look at the last Health and Wellbeing Board we had before lockdown, that's all about the wider determinants, tying in with the economy, thinking about what we can do as a council, but also, what can our other partners do? We've got the NHS as an anchor institution there that employs a lot of people, a lot of dealing with the local community. So it's thinking about what we can all do together, working on that Marmot community basis. So I would really recommend those areas really for some real focus. And I think finally as well, flu. We're going to have the winter on top of us. We're going to have flu and we're going to have people dying from flu as well as COVID. If you get COVID on top of flu, it's just going to be a complete nightmare. So we need to make a massive effort to get everybody vaccinated. So I would put that in as well.
Okay, Eileen, any other comments then, please? So, Eileen, thank you very much.
Sorry.
Sorry, who's this, please?
It's Russ. Sorry,
Russ, sorry,
my camera's off. I think the most striking part for me was about the impact in terms of other diseases that there hasn't been the diagnosis work and obviously the support and treatment. And Eileen rightly brought up about cancer. I mean, it's reported last week that there'll be 35,000 excess cancer deaths in the UK as a consequence of the last few months. I think that is absolutely startling. And when you look at the overall way that the country has dealt with COVID, with the economic smashing that we've taken as well. It really does kind of bring into focus, I think, how complex matters like this are with pandemics, because you kind of shift your focus to an immediate pressing problem and then just find out you've left yourself a few ticking time bombs elsewhere. I think I absolutely agree with that, Eileen. It's something we'll have to need some really strong focus on as we sort of emerge from this particular crisis.
Okay, thanks, Russ. Anybody else, please?
Could I just make a comment, Stephen? It's Catherine.
Yep.
So I just think one of the really important things Eileen mentioned quite rightly about the impact on people's anxiety levels and mental health. And I think one of the areas that we've really identified in adults is around carer stress in particular, because as a result of the pandemic, a lot of the usual support services have had to step back because of the social distancing requirements, which has left a lot of families dealing with stressful caring situations 24/7. So I think we do need to focus on strengthening the offer of carer support services, and also build on the fantastic work that's been done around galvanising volunteers in the third sector to support us in those endeavours around social isolation, which is often one of the determinants around people's anxiety.
Okay, thanks, Kath. Anyone else, please? So can I thank you very much, Eileen. Obviously, the health and wellbeing strategy, one of its key foundations is reducing health inequalities within the town. COVID's had the impact of amplifying and extending them, actually. So I think we need a report coming back to this board saying what are the actions we're taking in the context of a revised health and wellbeing strategy around the impact of COVID on health inequalities. So would it be possible for the November meeting if Simon Kenton can liaise with our new Director of Public Health, Thara Raj, who starts on the 1st of August, to pull together a report? Obviously, it needs to be a system-wide report, and we can have a look at some of the key actions. I think September's probably too early for that. I think November's more appropriate. Can we agree with that, please?
Yeah.
Okay, thank you very much. So move on to, again, Eileen, PHE report on COVID on BME communities.
Okay, I'll bring that up. Okay, thank you. Has everybody got this in front of them? This is a report that's come from Public Health England, and as you probably know, Black and ethnic minority groups have suffered disproportionately from COVID. And what this report does is it looks at that. It talks about the fact that, death rates are much higher for Black and Asian ethnic groups compared to the white ethnic groups. And usually we would expect to see all-cause mortality lower in Asian and Black ethnic groups, but with COVID, it's much higher. So it's 2 times higher, 3 times higher for Black males, 3 times higher in Asian males, and 2 times higher than white males. And also amongst females, deaths were 3 times higher in this period in Black mixed or other females, and 2.4 times higher in Asian females. So we've got a big increase there. Part of the increase is because the NHS has a lot of people from Black and ethnic minority groups working in it, so they were more exposed to it, really. But the other reason is because Black and ethnic minority groups are often more deprived, so that had a lot to do with it as well. But there are other things as well. So, for instance, Black and ethnic minority groups, because of their biological makeup, are more prone to things like diabetes and hypertension. And diabetes and hypertension is a key killer for COVID. So that's come into it as well. I suppose what I'm asking from you to think about today is the recommendations from PHE around changing that picture for Black and ethnic minority groups within Warrington. So what they're asking for, and you can tell me whether you've already got this or not. I think we probably have, but you'll probably know better than me. So we should have mandated comprehensive quality ethnic data collection and recording as part of our social care data collection and as part of our NHS collection. So we need to think about, have we got that? They're asking us to support some community participatory research in which researchers and community stakeholders come together and work with local BAME community to look at what programmes we could pull together to reduce risk for them and improve outcomes. So I suppose that's the kind of thing that Warrington Together would look at. They're asking that we look at improving access, experience and outcomes. So that's looking at integrated care partnership. How does that look for BAME people within Warrington? And we can work with partners across the piece on this. I don't think it's just a Warrington thing. Do we do culturally competent occupational risk assessments and have tools that can be employed in a variety of occupational settings so that we can reduce the risk of employees' exposure to COVID-19, especially for key workers? And that would be in the NHS and in ourselves in the council. It's looking at funding, developing and implementing culturally competent COVID-19 education and prevention campaigns. So thinking about, if we've got a campaign on around COVID, are we making it so it's suitable for our BAME communities? And are the messages culturally appropriate? Do we have everything in a selection of languages? Are we thinking about all that sort of thing? Are we targeting culturally appropriate health promotion programmes? So if we are commissioning Livewire, as we are at the moment for a lot of our health promotion stuff, is that commission culturally appropriate for BAME communities? And then also thinking about sustainable change. How come, are we including reducing inequalities within our health and wellbeing strategy? And I know that we are, but it's just thinking about, have we thought of BAME in there? So there's quite a few asks, and I think that it fits very well with the presentation because, you know, it's about health inequalities, and also CVD, which is a key killer for COVID, is the key thing for Black and ethnic minority groups because of diabetes, which has a huge impact on your heart, and also hypertension, which also has a massive impact on your heart and causes heart attacks and strokes. So, and COVID playing into that. So it's just thinking about all of that. Thank you.
Eileen, thank you very much. Any comments, please? Questions?
Yeah, can I come in, please, Steve? Okay,
please, Maria.
Yeah, welcome this report, and there's a lot of food for thought, isn't there? Sorry, I'll put my video on. A lot of food for thought here, and I think while we can all have good intentions, we may be missing some things. So I really welcome the recommendations. And I suppose my question is how are we going to focus that, how are we going to strategize that, and which organisations, you know, who's going to be identified as being responsible for following this through and making sure those recommendations are implemented. so we need to know that we are making progress on this. And I think a key is the stakeholder engagement with our BAME communities. So I think that's certainly one for the council, to really look at stakeholder engagement, but also for the health organisations in the town and other organisations sitting around this this board, how we're going to engage with the people who are affected most, and make sure that we listen to their voices and understand what it is that we need to change to get this right.
Thank you. Anybody else, please? Want to respond then, Eileen, please?
I think it's part of the Marmot work in a way. It's looking at those health inequalities and making sure that what we do addresses BAME groups, and some of this we can do, some of it partners will have to do. So I think it's about tying it in with that work and then putting an action plan together around it to think about how we're going to address it.
Okay, so could I just ask then, just to move this forward, if you take the recommendations which you refer to in paragraph 5 of the report, let's have a look at those and bring a further report back in November about how are we measuring up in reality to those recommendations. And secondly, perhaps to ask Health Watch to have a look at this issue and then come back to us again in November, perhaps with a joint report between the Council, Public Health and Health Watch. Is the Health Watch representative on the call, please?
Hello, yes, it's Ruth here.
You would be happy to do that, Ruth? Yeah.
I will take that back to the team, and then we'll liaise with Eileen and whoever else needs to be liaised with. Okay,
thanks very much, Ruth. So thank you very much for that, Eileen. Thank you. Move then to the next item: Health Protection Board outbreak hubs and outbreak hubs. So again, Eileen, please.
You're going to get fed up for me.
No, we're not.
You are. So this is just to give the board a briefing really on what we've been doing around our outbreak plans, and to let you know that we've set up an outbreak hub. I think a lot of people do know that we're doing this, but it's just to take a formal paper on this to the board. So as you probably know, we were asked by the 30th of June to have developed outbreak plans for complex settings and to have those published and to have them on Warrington's website, and we've done that. And just in case anyone's wondering what a complex setting is, it's a setting like a care home or a school or working with rough sleepers or a faith community or asylum seeking community. Is anywhere where you've got a lot of people together where if they had an outbreak it would be difficult to deal with. And that's what we as a local authority have been tasked with, dealing with complex settings. So we've developed plans. We've got 3 sets of plans on it. We've got 10 ways to prevent an outbreak. We've got plans for educational establishments. We've got plans for care homes, and we've got plans for other settings such as workplaces, homeless shelters, prisons, etc. So they're all up. So we've got that done. Lawrence Pullman has pulled together a comms media strategy to go with this. So we've got that. We've also tested our plans. We had a schools test, which lots of Warrington schools phoned into. That's all been tested. And the schools were really appreciative of that, actually. They all came back and said it was great to actually go through a scenario attached to the plans and see how they actually would work in practice. So we had a go at that, and that was really successful. Yourselves, through Stephen, have set up a local outbreak board, and that's been developed. So that's got elected members on it along with lead officers, and a statutory board that we have to have in place which we didn't really have in place before, is the Health Protection Board. And the Health Protection Board is answerable to the Health and Wellbeing Board. We had a Health Protection Forum before, but it wasn't as well developed as the board we've now got. And the Health Protection Board, and we had the first one this morning, now has a lot of people involved in it. It has all the hospitals, it has CCG, it has business, it has comms, it has children's services, adult social care. It's a big board now, and it has a lot of responsibility. That board is the working group to inform how we take forward our outbreak plans, what we would need to do in the case of an outbreak. What if we got into a situation like Leicester? We'd have to know what to do. That all goes through that board, and then that board then feeds into Stephen's COVID-19 group, which would sign off anything that the Health Protection Board's agreed to do. So that's how it works in terms of governance. We've also set up a local outbreak office. That had to be up and running by the 6th of July. So we have staffed that now. We've had complex calls coming through to us for the last couple of weeks. We've had complex cases around traveller families, taxi drivers, schools. So any complex case that comes through now that needs to be dealt with, that's coming through to that local office. And there's a phone number, which is in this paper. And there's also an email address for people to get in contact. At the weekends, at the moment, we have what we call SPOCs. So at the moment, that's Dave Bradburn and we take any phone calls that come through from PHE on complex cases. So we've been kept busy most weekends. We've also got to support our local outbreak office. We've got a Cheshire outbreak hub, and this is a hub which is covered by Public Health England plus a range of other staff that have been employed from across Cheshire. So you've got contact tracers, you've got call handlers, you've got clinical governance, you've got data management in there. So that's all up and running. And the idea is that once that's fully functional, because at the moment it's just Monday to Friday, that they will pick up that out of hours work at the weekend. At least that's what I'm hoping. So you can see the structure for that in your paper there. So at the moment, all seems to be going well. The other thing that's happening is that we're getting lots of information through from PHE on how we are doing as a local area. At the moment, it all looks good for Warrington, but there are going to be a number of triggers that let us know if we are possibly going to have an outbreak. And they will include things like our rate of positivity. If that goes over 5%, we're in trouble. Our infection rate per 100,000 and our trend. If we suddenly start trending high in terms of cases, we need to look quickly at what's going on there. Where are those cases? We need to home in on that geography. We need to test those people, get them to self-isolate, and we need to sort that area out really quickly. So there's a lot of work going on around all this at the moment. So I'm happy to take any questions.
Thanks very much, Eileen. Any comments or questions, please? Obviously, you've got a very complex set of governance structures there. Are you confident if we had to mobilise, we can mobilise quickly, Eileen?
Yeah, I think we could. Yeah. And I mean, we are still employing staff. So at the moment in Warrington, the staff that we've got are people that we've moved from other jobs into the local outbreak office. And the Cheshire hub is still mobilising. It is up and running, but it's not fully staffed. So if we did have a massive outbreak tomorrow, I mean, it would be all hands on deck. I think we'd cope, but I think, you know, it wouldn't be as slick as it would be if we had an outbreak in a couple of weeks' time.
Thanks, Arlene. Anybody else, please? Paul, please.
Thanks, Arlene. I was just wondering, within the terms of reference and the makeup of the group,
yeah,
I was wondering if there are any elected members who are going to be invited along as part of the membership.
Not at the moment. That's not what's been agreed, because the Health Protection Board is more of a technical task group, so it's full of technical expertise, if you like. I suppose where the elected members come in is on that COVID outbreak board which Stephen has set up, where if the Health Protection Board perceives there's a problem, they then go to that group, and then it would be for elected members to then think about what's going on and work together with Stephen on what they would want to see happen.
And the track and trace, how's that going locally? I'm just wondering, there's been some criticism of it on a national basis, but I was just wondering what it was like on a local basis, and if you're aware of what the reception has been of people that have been tracked and traced.
Well, I think that's a good question. In terms of track and trace, I think there are a few teething problems with it. I think that at the moment, what we're receiving is information about people who've been traced and where they live, but what we're not receiving information on is where they work. So somebody could be COVID positive, they could have been in a workplace, passed it on to colleagues, they get registered where they live, and all their colleagues can live in different places, and then you know, it's difficult to put two and two together and think, oh well, actually all these people that we're seeing coming through, they're all coming from the same workplace. We had that happen in Holton. We had an outbreak where we had over 20 people in one workplace COVID positive, and it took us a while to realise that actually they're all working together. And if PHE, when they first received details of the person who'd rung in, if they'd asked them, where do you work, that would have been really helpful. That would have been really helpful.
Has there been any change in the numbers with the pubs opening, or is it too early to say just yet?
It's too early to say just yet, because it tends to develop a few days after the pubs have opened. Yeah.
Maybe it's on its way. Thanks very much, Arlene.
On its way. Yeah.
Thanks, Paul. Anyone else, please? Okay, well, you said teething problems. How long it takes to develop a full set of teeth? But I guess the world beating system the Prime Minister promises some months ago, is it, Arlene? Really?
Yeah, really.
No. Okay. Okay, Arlene, can I thank you for your report? Thank you. Cheers. Thank you. Moving on then. Next one then is Lucy from the hospital. Tell us about the town deal plan and the health theme. Lucy, if you would, please.
Thank you very much. So I'm bringing this report as the health theme lead for the Warrington Town Deal Programme, and also on behalf of Steve Park, who leads the overall Town Deal Programme within Warrington Borough Council. I guess I wanted to start by echoing some of the comments right at the beginning of the meeting around the pace and scale of collaborative working that we've seen in the last few months in particular. And I think what the Town Deal brings us is a really exciting opportunity to put some of that enthusiasm and pace into practice and implement some real change for the benefit of the people of Warrington. So for those not familiar with the Town Deal Programme, I'll just give a really brief overview of the programme itself. So it's a national programme which is aimed at improving outcomes within 101 towns that have been selected nationally, and both Warrington and Runcorn have been selected as part of the national programme. The plan is led by Warrington Borough Council and supported by Atkins, who are some consultants who have been commissioned. And through the development of a plan, in terms of the Town Deal programme, the council can access up to £25 million to improve the outcomes for people within Warrington. And in terms of the overall programme, what we've done is develop 4 key themes, which together form the focus of the plan. So you can see them listed in section 3.3. So education, skills and employment, housing and infrastructure, health and wellbeing, and arts, culture and digital. And those 4 themes reflect the 3 key areas which nationally the programme is targeted at improving. So urban regeneration and land use, skills and employment, and connectivity. So the remainder of the report really just focuses on the priorities that we are looking at developing at the moment from a health and wellbeing perspective. So in that health and wellbeing theme of the 4 themes. So for each of those themes, groups have been established, and there's been some initial meetings of those groups to try to identify what do we think the priority things are for investment within those themes that would make the biggest impact in terms of improving outcomes. And we've had really amazing stakeholder engagement through those first couple of meetings. So including, for example, statutory providers of health and care, third sector providers, community interest companies, GPs, the chairs of all the organisations within Warrington together. So it's been really fantastic engagement and under what is quite a tight timescale. So that's been really helpful. So what you'll see then is through those initial conversations and also incorporating the feedback that we've had from the public, both via previous kind of engagement and consultation, and also via the My Town webpage, which has been set up specifically for this programme. Within the health theme then, we've developed 3 priorities, which we are still in the process of working up into some more detail. And they are, the first one of those is provision of health and a health and wellbeing hub in Warrington Town Centre. So provision of some health and care services in Warrington Town Centre. And this specifically actually relates to Eileen's report, which is really positive, I think, in terms of what are some of the things that are really, really important to our population right now, especially given the impact of COVID. So the types of services that we're looking to provide in the town centre include things like a community wellbeing service and signposting, mental ill health prevention, some services for older people, particularly in terms of frailty assessment and also prevention of falls, for example, potentially some minor illness and injury treatment, and also an integrated diabetes service, which I think talks directly to what Eileen was saying in terms of some of the conditions where people are at greater risk of contracting COVID and also have significantly poorer outcomes if indeed they do contract COVID. So those are the types of services that we would be looking to provide. There's multiple benefits to providing services like that within the town centre. For example, for making care more accessible and also reducing congestion around the town centre. Also encourages footfall into the town centre in terms of that economic regeneration and avoids the need for people to attend a hospital setting. Again, linked to Eileen's reports, the services that are being proposed target specific areas in terms of health inequality and where there's increased demand or forecast increased demand, either due to our ageing population or due to the impact of COVID. So the second area then, the second priority that we're looking to develop is the development of a health and social care academy. This is being led by Warrington and Vale Royal College in partnership with Chester University, and aims not to duplicate the training opportunities that are already on offer, but to link those to employment that is available within the town, and also to fill the gaps where there may be new roles emerging within the health and care sector where there isn't specific training yet available, and also to try to target some of that at our younger population that are out of employment, and also those returning to education. So for example, having some shorter courses available that enable people to access employment quicker. So that obviously helps in terms of development of skills and employment, but also the sustainability of our health and care sector where we have significant vacancies. The third area then, which isn't really explored in detail in the report, but that the Health and Wellbeing Group is contributing to significantly, is around the proposal to develop further active travel. So recognising the significant health benefits that active travel could bring. So in terms of next steps then, what each of the 4 themes, so the education, skills and employment, housing and infrastructure, health and wellbeing, and arts, culture and digital, have done a similar exercise in terms of trying to identify what the priority areas would be for inclusion within the plan. And we had a town deal board meeting on Friday last week, Friday the 10th of July, where each of the theme leads shared those ideas. So what the council is doing over the course of this week is reviewing those ideas and prioritising them for inclusion within the plan. Warrington Borough Council was given 3 options. Stephen, you might want to comment at some point, but around submission date in terms of when they would submit their first initial plan for the town deal programme. And those options were the end of July, the end of October, or the end of January 2021. And the council has selected the end of July. So lots of work happening at the moment just in terms of confirming what priorities will be included in that plan, and then ensuring that sufficient detail is within the plan to be submitted at the end of July. And there's a further board meeting in terms of the Warrington Town Deal Board on Friday next week, Friday the 24th, to review the draft of the plan. Following submission of the plan, if the plan is approved, we will essentially then be given permission to work that plan up in more detail into a full business case. And so that was kind of the main things that I wanted to say, really. It's probably just worth touching on engagement and consultation. So there's been quite a significant amount of engagement via the My Town webpage, and also we've been building on previous engagement and consultation, for example, carried out by Health Watch and through the Central 6 master plan process. I guess going back to Eileen's other report in terms of BAME, what we need to make sure is that any further engagement and consultation which we'll need to do as the plan develops is inclusive, and also specifically ensures that we include those BAME groups. I'm happy to take any questions or comments.
Okay, Lucy, can I thank you very much for your very comprehensive report. Any questions, comments, please?
I'd certainly.
Shall we take Ian Marks first?
Thank you, Lucy. It's always good to hear about these carrots from central government of up to 25 million. And then, of course, you just talked about the need to do a business case, which I understand. Forgive me for being a bit sort of sceptical about this, but how much money do we think we're actually going to get from the government when this is all over? Because we sometimes see these maximum figures, but it's actually quite difficult for us to get this. And do we think we have an idea which particular levers we need to be pushing to get maximum money out of this? And by the way, I'm sure you're right to go for the earlier date rather than the later ones. Thank you.
I'm happy to respond initially, and Stephen may like to also respond. But so my understanding is that each of the 101 towns that have been selected, there is an allocation of £25 million. So it's not a competitive process in that sense. So following the submission of the plan in the first instance, in our case at the end of July, we should at that point receive an indication of support or otherwise for the full value of the plan that we submit at that point. And then the next stage, as I said, it's working up a business case, but I think that's more about working up the detail of how we would deliver the investment. So from my understanding, I think our chances are pretty high, and I know that's not always the case, so I completely understand the question.
Okay, thanks, Lucy. Good luck.
Thank you.
I'll just take Paul and I'll respond to you, Ian. Okay, Paul, please. Paul Warburton.
Thanks very much, Lucy. It's great to see the hub being proposed in Warrington there, and the development of active travel. I was just wondering, within the bid, which is still in development, whether or not there's any thoughts about e-bikes for elderly and prehabilitation, because it sits really well with a number of things we've been discussing regarding diabetes and obesity and social isolation. And I was just wondering if there could be some means of bringing e-bikes into that, and then also it will enable us to develop active travel within the health and wellbeing hub within Warrington.
So I believe that is being explored through the Green Travel group and the Active Travel group, but I will take that back as well, and there's an opportunity to still feed that comment in, so thank you.
And I'll be happy to assist if you need any.
That's brilliant, thank you.
Okay, thanks.
Thanks, Paul. Anyone else, please?
It's Rebecca.
Rebecca, please. Yes, Rebecca. Thank you.
Yeah, I was very pleased to hear Lucy convey the sort of level of enthusiasm there's been about this project, and it's great that it's been able to proceed given everything else that everybody's doing at the moment. And I think that Ian had posed the question earlier, that picking up on Maureen's point, what are we doing about some of the challenges from COVID? Some of the things that are challenges from COVID are an amplification of the challenges that face us anyway. And I think that the proposals that are going to go forward with the town deal bid are very much aligned. So this is some of what we're going to do about it. And I think it's exciting that actually by the end of July this will have been submitted to the government and will be under active consideration. So positive steps, and I feel as though the things are really coming together. And I think I'd talked earlier about other areas of the council being increasingly engaged in work that impacts on health and well-being, and again this is an example of that, of sort of collective thinking that's all pointing in the right and appropriate direction. So there's some powerful stuff here, and stuff that has capacity to make a real difference.
Thanks, Rebecca. Anyone else, please?
Yeah. Oh, yes, Stephen, can you hear me?
You got your Maureen, yeah.
Oh yeah, sorry. Yes, I just wanted to add to that. I think one thing that's been really positive about the work we've done towards the bid is the amount of consultation work that we'd already done prior to the workshops for this bid. So I'm thinking particularly of the Essential 6 master plan, but I know there are other pieces of work that really helped us to have everything in place as soon as we went into those workshops. And that has really helped to shape the whole picture of what we're doing. So I'm looking forward to getting that bid submitted and hopefully getting a good result that will make a difference for the town.
Okay, thanks, Maureen. Thank you. Any further contribution?
Can I say something?
Yeah, Eileen, yes, please.
Yeah, just to say that it's great, isn't it? Because it, you know, like everyone says, it just ties in so perfectly with what we were talking about before in terms of tackling health inequalities. If we've got a health and wellbeing hub in the centre of town, and and we've got we're looking at diabetes and hypertension and falls and all that sort of stuff that we could do as part of that hub. That's just fantastic to bring all that together. It really helps us tackle everything. Thanks.
Thank you. So, Ian, to answer your question, we felt, first of all, it's all capital. It's 25 million capital. There will be some revenue implications, but it's capital funding. We thought that as government's been very strong at the moment in terms of state intervention with taxpayer resources, better to go now in wave one before perhaps other initiatives come along that take their focus away from it. So we thought we'd go with this. It's got strong support from both MPs. The MP for Warrington South has been very, very strong in supporting this, and I've asked him to make sure it follows its path through government. So those are the reasons why we've gone with it. I think we will get £25 million in, but it's capital, not revenue.
Thank you.
So can I thank you very much for that, Lucy, and I think we've been asked to note this, and also to note the particular priorities within it, as you've described, the two major schemes within it. And we'll pick up the points that Paul Warburton made around e-bikes. We'll pick those up. So thanks very much. Moving move on to Health Watch annual report. So it's here. Health Watch, you want to say a few words about your annual report, please?
I can do, though. My agenda indicates that the hospitals have got a strategic update now.
Yeah,
I'm
sorry.
happy to go, but I didn't want to mess up your order.
Yeah, sorry, I'm an absolutely crap chairman. Let me take you now.
No problem.
And we'll go back to the hospital. So take Health Watch now. Sorry, Ruth. Yeah.
Oh, fantastic. No worries. Well, thanks ever so much for allowing us to come and listen to the fantastic work that's been underway, and it really helps to hear all of this brought together like this. And I imagine everybody listening publicly will be really appreciative of the hard work that's going into Warrington at the moment. So for those listening who aren't familiar with Health Watch, I'll just give you a quick overview of who we are and why we exist. So we exist to bring the independent voice, and that would be experience, ideas and concerns of the residents of Warrington, in the hope that by bringing that we can support the health and social care partners around this table, make the best decisions and improve services in Warrington. And so a little bit of background is that we have 2.5 full-time equivalents of staff, and they are ably supported by around 17 volunteers. Of those volunteers, we have a Health Watch Advisory Board, of which I'm chair, and that's why I'm here today to present the annual report. Having listened to what I've said, I thought it might be worth mentioning, I quite liked what Council said about, I think some of the reports that have been brought are definitely amplifying the challenges that have already been identified potentially through Warrington. And I think that some of the work that Health Watch has done to COVID lockdown, hopefully you'll see once you see those reports that they sort of support that as well. So if I go back to the report, which I hope you've all had a copy of, the way that the Health Watch Advisory Board works is that we help Health Watch to prioritise what they're going to specifically prioritise that year. We tend to do that based on what public feedback is, so what the public are telling us they want us to concentrate on. But we also try to align it with the strategic priorities of this forum as well, so that we're supporting our partners hopefully as best that we can. So during 1920, we had focuses on maternity, and that was the experience of people receiving maternity care. We also helped set up a people's panel which supports Warrington Together in making its decisions. And we also conducted a young people's mental health report, which looked into that access that those people are experiencing for mental health in Warrington. Now, the reason that's not been published as yet was because as COVID hit, clearly everyone's attention went elsewhere. So we're currently in the process of waiting to meet up with Simon Barber and the CCG just to discuss the content of that before we release it, so that they have a chance to comment on that. But as soon as we have that, we will release that, and I hope that that will help feed in again to things we've heard about already around mental health and access for our population. So just briefly then, the reach that we've had this year in Health Watch in terms of the number of people we've interacted with and hopefully affected has grown this year. So we've managed to give information and advice to more than 3,700 people. We've had more than 16,000 hits on our newly revamped website, and we've had more than 4,000 interactions on social media, as well as more than 200 face-to-face interactions with people during outreach activities. And all of that sort of information we feed back in various ways into the various organisations that they pertain to. The impacts, just to list a couple of impacts that we feel like it's worth highlighting, because it's okay getting information, but it's what you do with it that counts. And quite pleased to say that our Burton Wood survey resulted in reinstating of the community bus to get residents to and from the GP practice, which we feel is quite a good win. And also similarly nationally, we were involved with a survey to get the people's views from Warrington on the long-term plan strategy. And nationally, that resulted in NHS England reviewing their patient transport provision, because it was something that they'd actually overlooked during the long-term plan. So we felt that that was quite a good impact as well. And just briefly before I leave, I thought I would just give you a quick COVID update, if that's okay, which is that the team have clearly been working remotely, which does change the way that we interact with the public. We've been using a lot more social media and been trying our best to promote things that are released by the CCG, for example, to help get messages across that are needed for the residents of Warrington. and we've been undertaking a COVID-19 survey, which looks at the experiences of the people of Warrington in trying to access services through COVID. That's currently being analysed, and the hope is that that will be useful to the organisations as they plan for the next wave. But as I say, like Councillor Knoll says, the amplification of previous challenges is definitely something I'm hearing here. So things like the pressure on carers is obviously massively impacted by COVID, but it was something that we'd actually identified as an issue, and the public had helped us identify as an issue by voting for that to be our priority for the coming year, looking into carers. So we're currently exploring ways that we can do our work with carers remotely in anticipation that there may be other waves. So yes, lots going on, and hopefully you'll find the report interesting.
Okay, thank you very much for your report. Any comments, questions, please?
Yeah, I've got a quick question. Thank you, Stephen, and thanks, Ruth, for your report. It's really positive to see all the work you've been doing. I suppose this comes on the back of the COVID BAME report, and I'm wondering how you are ensuring you get those voices heard from our BAME communities.
I'd have to ask this is going to sound completely like a cop-out, but I am non-exec, but I can definitely I can check, and I am sure that there will be processes in place to make sure that they are representative in the way that they gather information. But I will have to ask specifically if they've thought about that, because I do think it's something that we need to be reflecting on in Health Watch anyway. So yeah. I think just like every other organisation needs to reflect on our roles in ensuring BAME populations are supported, it's a process that we need to go through as well. So presently I'm not sure how it is assured, but I am sure that we are reflecting on making sure that it is going forward, just like every other organisation is, I hope.
Okay, thank you.
Does that help?
Thank you, Ruth. Anyone else, please? Well, Ruth, can I thank you and your colleagues for your diligence and your work. I think we're feeling really confident about Health Watch. So in the life of this board, it's not always been the case when other people have the contract for Health Watch, but thank you for all your work you've done. And so we just note and receive your report then. Thank you. So then, Simon Constable, you won't take me to A&E. I've delayed you. Sorry, Simon. Over to you, please.
No problem, Chair. Thank you very much. I'm happy to wait my turn. So I'm very happy to deliver this report. Originally, I think in the work programme as longer-term strategic priorities, but I think rather a lot has superseded since then, since January. And I thought it was more helpful to give what is effectively a situation report and our more immediate strategic priorities as an organisation. So what's here is a summary of the situation at the hospital, our hospitals over the last few months, and what our current issues are, and very happy to take questions on that basis. So just a bit of an opening statement then really into where we're at currently. Clearly as an NHS organisation, we responded immediately to the NHS England National Level 4 emergency back in March. And what I present here really are the headlines of our position in terms of numbers of patients that we have looked after and the issues that we are dealing with currently. So just some context and just to update the figures that have been provided to live, what have been provided in the report. Up to this point, we've tested over 11,000 patients in either hospital or community patients, and I would stress that the key word there is patients. So these are members of the population who have sought healthcare in one way, shape, or form. These aren't necessarily asymptomatic patients, and approximately 10% of those have tested positive for COVID-19 since the pandemic began and since we saw our first patient in March. Fortunately, only a very small percentage of those patients have actually been required admission to our hospital, and in total approximately just over 500 patients we've looked after since March. And at the time of writing, approximately 376 patients have been discharged from hospital, and sadly 135 patients have died in hospital. I'm pleased to report there have been no further deaths in the last week. As predicted, pretty much, we achieved a peak of 124 patients in total in the hospital testing positive for COVID-19 over the Easter weekend. This was very much spot on the predicted timeline, which falls approximately 3 weeks after the Prime Minister announced that that we were going into lockdown. But the peak was substantially less than the worst case scenario prediction that was made back in February. 124 patients is, however, just into context, effectively, if you think about it, is nearly still 5 wards worth of patients affected by COVID-19, so it's not an insignificant number, but it is substantially less than could have otherwise been the case. There was obviously lots of concern. This is predominantly a respiratory illness, and at one point a lot of the concern was around critical care capacity in the United Kingdom. We were asked to upscale our usual capacity in critical care, which usually sits at 18 beds in critical care at Warrington, to actually 5 times that, to go up to 90 critical care capacity. Fortunately, that was never required. I think the most that we actually achieved at one point was just in the early 40s. I think 44 patients, of only 24 of those were actually COVID-19 patients. The others were non-COVID related critical care patients. So still short of the worst case scenario that we were being asked to get ready for. As I sit here today, we currently only have 14 patients who remain COVID-19 positive. One of those, unfortunately, remains in critical care. The numbers of patients, if you think about the peak back in April, has actually come down incredibly slowly, really reflecting the picture in the rest of the Northwest. It's something that we've seen across the board. I think it is possibly worth stating at this particular point the kind of things that didn't happen, given the narrative that emerged in terms of staying at home, the public health initiatives to protect the NHS, to stop the NHS being overwhelmed, and indeed to save lives. And so that narrative of public health measures to protect the NHS and the impact that it has, we didn't become overwhelmed. So we didn't run out of any bed capacity. And in fact, I'm sure I've sat in many health and wellbeing boards previously in previous winters, talked about how challenged we were for bed capacity. That didn't happen during the pandemic, largely thanks to the behaviour of the public, but also for some of the significant system working that both Kath Jones and Simon Kenton have alluded to at the opening of this meeting. We never ran out of critical care capacity. You will recall there was much media speculation early on about the need for many more ventilator machines, when actually that never materialised for us. We never ran out of equipment, and indeed we never ran out of personal protective equipment either, largely through to a very successful local mutual aid scheme across Cheshire and Merseyside and the Northwest. And the other point of reassurance is no clinicians had to work outside of their usual professional capacity to any significant extent. And that was something very much a concern and anxiety of the clinical body, bearing in mind the look to what was going on in Italy in March and how medical staff there were operating. Staff sickness peaked at just over 17%. again, significantly better than the worst case scenario that we were being asked to model for, but still significantly higher than our usual sickness rate, which did indeed limit our capacity to deal with that would have, under normal circumstances, led to difficulties with our ability to deal with capacity. But fortunately, because of everything else that had happened, we were able to operate within safe limits. And indeed, as I sit here today, staff sickness is still double our usual level of sickness at just on 10% because of shielding, because of self-isolation, and indeed because of non-COVID sickness. For the most part, we have continued to deliver, obviously, emergency care. We did see a substantial fall off in access to emergency care during the peak of the pandemic, but those have pretty much subsequently, over the last month or so, approximated normal access levels for emergency department attendances. We continue to deliver high priority cancer and urgent work, obviously. The challenge remains now in terms of managing non-COVID elective activity, coping with a backlog alongside good infection prevention and control alongside COVID-19 management in the event of a second or subsequent peak. And part of that clearly also is about restoring public confidence in accessing planned and unplanned care in the context of preventing transmission of infection between patients and staff, and between staff members. And Eileen has already alluded to the significant concerns that emerge about particularly time-sensitive conditions like cancer, where our early diagnosis and early intervention is important, and that is a big focus of not just us in Warrington and Holton, but across the whole country, particularly in Cheshire and Merseyside, where we need to do our very best to establish normal diagnostic capacity as much as possible, especially with certain diagnostic tests such as endoscopy, camera examinations, which require particularly scrupulous infection prevention and control, and limit the ability that we have to deliver on normal capacity. Separation of patients and patient flows is going to be key to good infection prevention and control now, and indeed we've managed to achieve that with clean pathways, green pathways within Warrington Hospital for more urgent cancer operations. But at the heart of our recovery with regards to elective procedures is going to be Holton Hospital, which started reopening activity from elective programmes, including ambulatory trauma and breast surgery within the last few weeks, and Holton is going to be very much central to our strategy for separation of patient flows. And finally, I think at this point I'd be very happy to take questions, but like to put on record my thanks for the local community for their support over the last few months. That has been absolutely fantastic and has lifted the spirits of staff in a significant way during a significant period of anxiety, as you might imagine, for them as we deal with the unknown. But also the local system working, the local system leadership has been actually pivotal in that, and whatever we've done, we need to capture and move forward with it. I am very happy at this particular time to answer any questions, so thank you.
Hey, Simon, thanks for the detailed, comprehensive report. Thank you. Any comments or questions, colleagues, please? Okay, thank you. And thank you, Simon, for the part you played in this. It's been really very, very responsive. Thank you, Simon. Okay.
Thank you. Appreciate that.
Okay, move then on to next report, which is employment opportunities for people and disabilities. I don't know quite who's taking this report. So is this you, Simon Kenton?
Tim Smith here, Chair, if you can hear me.
Oh, are you there, Tim? Okay, thank you, Tim. Thank you.
Okay, I'll press on. So this is a report as was originally intended for the March board, but I will reflect and update on current circumstances as we go along. Just for context, this is a report about support for people, moving people into jobs, specifically about people with disabilities, and a bit wider about people with multiple barriers, complex needs, people furthest from the labour market, whatever phrase we might use. But just, I think, first to give a bit of context on the impact of COVID, I was looking at the claimant count figures, which have just been updated this morning. Now, the claimant count measures the number of people who are claiming universal credit with the requirement to seek work. Now, in old language, that would have been the number of people claiming job seekers allowance. It's just, you know, the new benefit regime. Now, the claimant count in Warrington has risen from 3,200 in March to 6,800 in June, just across 4 months there. So it's more than doubled. Now, one way of looking at this is that there are thousands now of what you might term re-employable people claiming benefit, and their main barrier is that their job doesn't exist anymore. But when things do start to pick up and employers are re-recruiting, it could be something of a buyer's market for them with all these, as I say, re-employable people applying for those jobs. And experience from previous recession 10 years ago tells us that our target groups that we're talking about here could well get pushed further back in the queue. So that's just context and impacts of COVID. I am coming in with a bit more positive stuff later on. Section 3, if you could look at, I'm not going to read you through all of this, but Section 3 gives you a kind of a feel for the scale of things in Warrington and how many people in these different target groups are we talking about. I updated these figures with help from our public health statisticians before Christmas last year, but they tend to come out annually at best, so I think we can take these figures as giving a reasonably current picture of latest numbers in Warrington. Don't get your calculator out and start adding them up. They're not necessarily you know, 1 + 1 + 1 + 1, because they might overlap and people might fit into different categories. But just a note there of the scale and numbers involved in Warrington. Knowing what's coming next in my next section, I would draw your attention to learning disabilities and 2,700 people having a learning disability, because I'm going to talk about that in a second. So Section 4 shows some key indicators regarding employment rates of working age adults with disabilities and how does Warrington fare against Northwest and national rates. I'm going to do this in a slightly different order just to make it easier for you, I hope, because for example, 4.2 and 4.6 measure the same thing, which is secondary people receiving secondary mental health services. Now in 4.2, that measures just the proportion of those people that are in work. So a higher figure is better, and Warrington looks like it's doing okay there. And 4.6, that measures the gap between people with secondary mental health services, accessing those services, the gap between them and the gap between the overall employment rate. So in terms of a gap, you want the gap to be lower, so a lower figure is better. And again, Warrington doing okay. So 4.2 and 4.6, people receiving secondary mental health services. However, not good at all when we look at 4.3 and 4.5. This is people with learning disabilities. So 4.3 is the proportion of those people who are in employment. So a higher figure would be better, and Warrington is lagging behind there, not good at all. And 4.5 is the gap between people with learning disabilities and employment and the overall employment rate. So a lower figure would be better, and again, Warrington not coming out very well at all there. So learning disabilities, back to my figure in Section 3, about 2,700 people, learning disabilities particularly jumping out at us. And then finally, in the middle of that section, 4.4, a much higher target group, but people with a long-term health condition, the gap in their employment rate and the overall employment rate. So a lower figure is better. You want the gap to be lower, and Warrington's doing okay. So a much wider target group there, but learning disabilities is jumping out at us there. Section 5, given today's audience, I feel that in some ways I'm preaching to the converted very much here, but Section 5 just talks about the benefits of being in employment for the individuals themselves, their benefits to employers, and demonstrable benefits to the public purse as well. So I'm very happy in terms of having support for people with disabilities and other complex needs into employment as you know, being raised on the agenda here. Now, a couple of opportunities and things that are in place to support that area of work. Section 6, one is supported internships. Now, specifically aimed at young people aged 16 to 24 who have a EHC, sorry, Education, Health and Care Plan. So that's a workable model, demonstrable successes in that, and a model that could be widened to other target groups. However, we need more, so we need employers offering more opportunities to really make this work. So whilst we can offer hands-on support, there's a feeling of, you know, needing a wider employment base and more offered coming forward. And I'll just come back very briefly to employer engagement later on. Section 7, Journey First. Yes, European funding does still exist. Journey First is about to go live. However, I'll have to update that date there of 1st of June 2020. We'll now be taking our first participants from October 2020. There's been a little bit of a shift in profile there, but the project will be running into 2023. 7.3 has I would say a not exhaustive list of target groups, but you use it for indicative purposes. But in general terms here, we're talking about people of all ages who have significant barriers to employment, as I alluded to earlier, not necessarily the claimant count of people whose barrier is simply that their job doesn't exist anymore. We're talking about people with much other things going on in their lifestyles. Now, the model of this project recognises that there are many people in these groups who are known to council and other partner services. However, we tend to take a more supportive or welfare or pastoral role in terms of how we're helping people, and we have limited capacity presently to be saying to them, right, how can we help you look for work and support your move towards and into employment? So what this European funding will do will help us to increase that capacity, and if you like, in terms of a team of kind of specialist recruitment consultants, if you like, so people who will be liaising between the participants themselves and potential employers, and helping with job brokerage and helping them also with in-work support. So once people have managed to find employment, then we'll also be helping them for 3 months, 6 months or more in terms of making sure that things are sustainable. And finally, there's more going on in Section 8, for example, disability confidence. We have a sort of supportive network in Warrington of disability confident employers. We're trying to get more signed up to disability confident, but equally importantly, I think, is moving people who are at level 1, which is committed, up to level 2 and level 3, which means they've actually done something. So they have employed people with disabilities, or they're even mentoring other disability confident employers and showing off their good practice and spreading that. Access to work, for example, is still operative, so adaptations in the workplace or transport support and so on. So just moving into a summary of the report and conclusion. So COVID I think could well make things even harder in terms of trying to support people from these target groups into employment. Employer engagement might be harder in terms of it's a buyer's market, or it might be a little bit easier in the feel of we're all in this together, and we'll see how that pans out. So, you know, our employers feeling well versed in terms of employment and unemployment situation, seeing what we see on the news all the time, are they feeling a more active player in their local communities? So you know, we'll have to emphasize that on the we're all in this together kind of line when we're doing that. And when we're talking to employers, both private sector, public sector, third sector, including, you know, partners around the table as well, 9.4 sets out some of the kind of things that we would be trying to talk to them about in terms of smoothing the route into employment for people with disabilities and with complex needs and multiple barriers. So we're talking about work experience, we're talking about volunteer opportunities, job carving and so on. So there's a few things there. There is a lot of hands-on support and indeed financial in some cases, given what's come from the Chancellor recently. So we will be seeing how best we can use that to make sure that we can lever in as many opportunities as we can, emphasising the target groups that I'm talking about, not just the wider economy and the fallout from COVID. So the recommendations are for the board to know, and that things haven't stopped. There is a good level of support coming, and that we need employers to be willing to play their part in offering opportunities for our target groups. I'll pause there for any questions. Thank you.
Thanks very much, Tim. Any comments or questions, colleagues?
Yes, I'd like to come in, Stephen.
Thank you,
I
Maureen.
found it's a really useful report, and the data's really clear and helpful. I wanted to draw out something about universal credit, which Tim talked about, possibly people being pushed to the back of the queue with the amount of the high levels of unemployment coming through COVID. But also, we know that those people who claimed universal credit because of COVID actually were given an extra £1,000 because people were horrified at how little people were actually getting on universal credit. As I understand it, those people who had disabilities or were seeking work but were furthest away from getting close to employment were still on that lower rate and haven't been given that £1,000. And I think there's a real unfairness there, that things should be equitable, particularly when it's going to be much harder possibly for those people to find work with such competition now. But I was heartened by a lot of what Tim said about the work that's going on, and particularly about the disability confident employers. And I suppose I'd really like to push that and see the council championing that, because as it says in the report, people with disabilities can bring a lot of value to a company, and it just needs that confidence to go ahead with that. So really hope to see that pushed and encourage businesses across the town to really think about that aspect of what they do.
Thank you, Maureen. Thank you. Any other comments, please?
Chair, thank you. It's Steve Cullen from Citizens Advice.
Yes, dear.
Tim, we welcome the report. As you know, we've always been supportive of your team in the work that you're doing, and we've been involved in several ESF projects in supporting people into work. And I agree with Maureen and some of the comments you've said about some of the challenges. I suppose one of the cautions really is, you know, many of these people have faced a really hostile benefits environment for the last few years, where, you know, some of our most severely ill and disabled residents, you know, with a combination of mental health and physical ill health, and even people with terminal cancer have been told that they're fit for work, that they've got no illnesses, poor decision making in the DWP alongside their privatised companies that they work with, Atos, Capita, G4S, etc. So it's really a tough journey for them. You know, some 85% of the appeals that we do to independent tribunals, the DWPs and the contractors' decisions are overturned. And, you know, Maureen mentioned the benefit system, people coming off legacy benefits and trying work out and then finding it's not successful and going back end up significantly worse off. So I suppose really it's how we can work together in a positive, supportive manner without putting people at risk. You know, people losing significant incomes or even being told they're not ill when they are. You know, Eileen mentioned before some of the triggers for toxic stress, and it does worsen people's physical and mental health really. So it's just a plea of how we can work together in a supportive way and not fall into the trap of the DWP with sanctions and you know, forcing people with conditionality, etc. It's a tough enough call anyway for you, you know, but I'd hate us to make people's lives worse, you know, by pushing them down a route that's going to make them end up worse off at the end of the day.
Okay, Steve, thank you very much. Ask Tim to comment in a minute. Just bring in Rebecca then, please. Rebecca Knowles.
As somebody who has a disability, this is a very much lived experience for me, and I suppose I was quite inventive, finding myself some, it's not exactly employment, but stepping up and becoming a borough councillor. But I think echoing the points that Steve and Maureen have made, people's self-esteem can take an absolute battering, and I think there may be some clues that we've got out of the COVID situation to connect with people slightly more successfully, and actually doing so virtually is something that can be very appealing to people who, particularly perhaps who have mobility disabilities. And I can also see the application to people with things like hearing and sight impairment, in particular, where technology can really be their friend. Just joining the dots up at the last week or two, I've seen some of the stuff that some of the schools have been putting out in terms of virtual careers fairs, and followed a few links through there to employers that are offering things like virtual internships. So for me, it's a plea to really be creative and bearing in mind and acknowledging everything that's been said about people feeling as though they may well be even further disadvantaged and at the back of the queue. Can we find some creative ways to give people some meaningful opportunities to engage using technology imaginatively where we can?
Okay, thanks, Rebecca. Other comments, please?
Stephen, can I just come in? It's Amanda.
Hi, Amanda.
Hi, yeah, just to say, I think there's been some really good work go on around here, Tim, between yourself and Neil and your teams. I do think there's been some delay because of COVID, so it's good to see the report, because obviously we're going to start getting back on track with all this work now. I'd just take the opportunity to remind myself and remind other people on the call that actually we are big employers ourselves in the town. So actually between us, we can make some of this happen ourselves and lead the way really, and support Tim and Neil in the work that they've been doing. And a final plug for our care leavers, I'd just remind us all as well that of course our care leavers have been our looked after children in the town, and we've got corporate parenting responsibilities to those as well. So any opportunities we can create for these vulnerable groups, I'd absolutely want us to get behind.
Thanks, Amanda. Anyone else, please? So, Tim, any final comment from you, Tim?
Yes, I'm just going to respond in positive terms, if I may, Chair. And thanks, Amanda, for sort of emphasising the a little bit of peer pressure there, if you like, and reminding partners that we ourselves are large-scale employers quite often with an opportunity to lead by example. Just responding to Maureen and Steve just quickly about benefit circumstances and so on. What we're not doing here with this with Journey First programme is having it sort of as mandated referrals from Job Centre Plus. And when people are on disability related benefits, after their assessments, they're generally put into either the work related activity group with a government phrase like work is feasible in the short to medium term, or something, I think along those lines. Or they're put in the support group, and I think 60% of people tend to be in the support group, people claiming disability related benefits, where work in the short term is not a feasible solution. However, as a very broad generalisation, nobody's really doing anything for those people. And what Journey First seeks to do is to also reach out to people who are in that support group with a view to helping them, you know, maybe do a bit of volunteering or just something for half a day a week or 1 day a week, just building a bit of a routine, raising their self-esteem. And by which that would also raise their mental health and their physical health perhaps as well. So it's quite a wide remit. It's not a strictly payment by numbers, you know, number crunching, get big volumes in without a second thought kind of program. There's quite a wider remit of just generally trying to do the right thing here.
Okay, thanks, Tim. So I thank you, Tim, for your report and the recommendations, and the point that Amanda made about, you know, we're trying to employ a lot of people and we try and promote this within our workforce, please, if you don't mind. So thank you very much, Tim. Thank you. Then moving on to item 12, primary care strategy. Carl, please.
Chair, thank you very much. A very brief update on where we are with the primary care strategy, which should have come in March, but I'll explain why it didn't. We've been working over most of last year with stakeholders, the primary care workforce, patients and citizens to develop a primary care strategy that would set in the context of the NHS long-term plan and would take us up to the end of 2022. The strategy, high-level strategy, came to this board in July 2019. We took comments from the board, they were incorporated into the strategy, and we were also put in touch with other groups, such as some of the neighbourhoods, where we engaged with other stakeholders in terms of making sure that the strategy was fit for purpose. The strategy was then pulled together with support from the graphics team at the local authority. This was worked up and probably not far off ready to hit the send button, and then we went into a pandemic, COVID-19, and it was paused. However, in recovery during July, we've reinvigorated the work, and the key bit of work is making sure that it is aligned with the new direction and guidance that's come down as a result of COVID-19. And one of the things that COVID-19 byproduct has helped us do is accelerate some of those things. So development of the primary care networks, they've been to the fore in terms of our response, and also the wider and greater use of technology, which is one of our aspirations in the strategy, have been driven forward. So there's a key piece of work in July to make sure that is aligned to the standard operating procedures that have come down from NHSE and NHSI, and we hope to have a final version to come to the next meeting of the Health and Wellbeing Board.
Okay, Carl, thank you very much. Any comments or questions, colleagues? Okay, well, so we'll try and target this to come strategy to the 10th of September. Carl, does that sound about right?
It does, yeah, that sounds definitely doable.
Okay, thank you very much. So in terms of the work programme, that's item 13. Jenny Cobble and I'll meet and tidy that programme up. We've added a couple of items, I think, for the November board meeting. So just before I finish, can I just thank Eileen O'Meara. This is your last meeting of the Warrington Health and Wellbeing Board, Eileen, for all your good work. And if you could just switch on to take yourself all off mute, please. You're going to give a little round of applause for Eileen, please. Okay. Okay. Thank you very much, Eileen. And the meeting is on the 10th of September. Thank you.
Oh, thank you. It's much appreciated. I've really enjoyed working with you. It's been great.
Thanks, Eileen. Cheers. Thanks, everyone.
Thank you, Ollie.
Okay.
Thank you.
All the best. Bye. Bye.
Bye. Bye.
Bye.